I'm John Strum, and this is RealTalk MS. It's June 9th, and we have a lot to talk about. But before we get started, I think it's important to acknowledge the pain that each of us is feeling as we grapple with the injustice and violence that led to the death of George Floyd and so many others before him. I don't know whether you've already heard or read this, but in the past week, the National MS Society's president and CEO, Cindy Zagiboilo, released a statement that I'd like to share with you. We are outraged by the injustice and violence that led to the death of George Floyd and too many others in our country. This is not okay. Not today or any day. We realize that our heartbreak and anger are not enough. We must do better. We must do more. The National MS Society is committed to creating a world where everyone of every race can live a life free of MS and free of injustice and inequality. We recognize the effects of MS on the Black community are magnified by the inequities in our healthcare system. We will not be successful in finding the cure until we confront and address these inequities. The disparities that keep Black people from receiving today's care must not keep them from receiving tomorrow's cure. We are a movement by and for people affected by MS. We are listening. We stand with you today and every day. And I'll just add an amen to that and share my own opinion that the inequities in our healthcare system represent just a single aspect of the injustices that members of the Black community have endured and continue to endure. They say that recognizing that you have a problem is the first step towards solving it. And I think it's finally becoming clear to more people than ever before that we have a problem. And I'm hopeful that our country is about to turn a corner on beginning to right the wrongs that have been created by systemic racism. Turning to more routine matters, if you missed it, a bonus episode of RealTalk MS was released this past Saturday. In it, I'm joined by internationally certified MS nurse Sherry Binns for a recap of last week's Consortium of Multiple Sclerosis Centers annual meeting. Like every other conference taking place right now, this was a virtual meeting, and there were some outstanding presentations, including one by my guest on today's podcast. So in our recap of the conference, Sherry and I get into aging in MS, managing mood and depression, the latest information on diet and exercise, and more. If you haven't had a chance to listen to this bonus episode, you can find it at realtalkms.com/CMSC2020. Or, as always, you'll find it on Apple Podcasts, Google Podcasts, and all the places that you find your favorite podcasts. I'll include a link to our special CMSC virtual meeting recap episode in today's show notes. Well, that brings us up to date, and joining me today is Dr. Jennifer Graves, an associate professor of neuroscience at UC San Diego Health and the director of the UC San Diego Neuroimmunology Research Program and the director of the Rady Children's Hospital Pediatric MS Clinic. Dr. Graves studies how age affects patients' experience of multiple sclerosis, along with genetic, environmental, and sex-related risk factors that drive clinical outcomes in MS. And we're talking about changes in managing MS through the different stages of life. But before we get to my conversation with Dr. Jennifer Graves, there are a few other things that you should know about. At the end of this past March, the FDA approved Zeposia, a disease-modifying therapy that treats relapsing, remitting, and active secondary progressive MS by preventing immune cells from entering the brain and causing inflammation. Zeposia is a daily oral capsule that works in a manner similar to Gilenya and Mayzent, and Zeposia's manufacturer, Bristol Myers Squibb, claims that Zeposia has a better safety profile and causes fewer side effects than either Gilenya or Mayzent. Now, at the time that Zeposia received its FDA approval, Bristol Myers Squibb announced that they were delaying the rollout of their new drug while our healthcare system was completely overwhelmed trying to treat patients with COVID-19. And last week, Bristol Myers Squibb announced that Zeposia would now be made available in the United States. Also last week, Zeposia was approved for adults with relapsing remitting MS by the European Commission. So if Zeposia sounds like it might be an option for managing your MS, now you can start having those conversations with your neurologist. And if you'd like more information about Zeposia, you'll find a link in today's show notes. While we're on the subject of gaining FDA approval for disease-modifying therapies, the FDA announced that it was delaying its ruling and extending its review of ofatumumab by 3 months. Now, ofatumumab is a potential MS disease-modifying therapy from Novartis. It's commercially known as Arzerra. And FDA approval of Arzerra was expected this month, and now that date has been moved to September. Neither the FDA nor Novartis gave any reason for extending the review, and it's a little unusual because Arzerra received FDA approval to treat leukemia more than a decade ago. So it's clearly not a safety issue, which means that the FDA may be requesting additional information about the clinical trial that demonstrated the effectiveness of Arzerra among MS patients. Whatever the specific issue may be, we should expect to see Arzerra gain FDA approval this fall, and then gain approval from the European Medicines Agency in mid-2021. There's also encouraging news about yet another potential disease-modifying therapy. Last week, EMD Serono shared data from the open-label extension of its Phase 2 clinical trial for evobrutinib. The new data showed that evobrutinib not only maintained its safety profile, showing no new infections for 2 years among 1,200 study participants, but importantly, evobrutinib lowered MS relapse rates over that same 2-year period. As I said, this is encouraging news as recruiting will soon begin for 2 Phase 3 clinical trials that will evaluate evobrutinib among 1,800 participants. These Phase 3 trials are expected to conclude in 2023. And last week, the European Medicines Agency approved a shorter infusion time for Ocrevus, which is already an approved treatment for relapsing remitting MS and primary progressive MS. The approval means that MS patients in the European Union can look forward to receiving a 2-hour infusion every 6 months, instead of a 3.5-hour infusion twice a year. Now, in the U.S., the FDA is also reviewing a request to shorten Ocrevus infusions to 2 hours, and that decision is expected by December 14th of this year. Disease-modifying therapies are central to managing MS, but managing MS changes as people age. My guest today is Dr. Jennifer Graves, and Dr. Graves studies how people experience MS through different stages of life. Her work has furthered our understanding of the difference between our chronological age and our biological age, and what that means when it comes to treating MS. In just a moment, we'll meet my guest, Dr. Jennifer Graves. My guest today is Dr. Jennifer Graves, an associate professor of neuroscience at UC San Diego Health. Dr. Graves also serves as the director of the UC San Diego Neuroimmunology Research Program and the director of the Rady Children's Hospital Pediatric MS Clinic. Dr. Graves partners with patients, families, and the MS clinical team to provide comprehensive care for people of all ages. She studies how age affects patients' experience of multiple sclerosis, along with genetic, environmental, and sex-related risk factors that drive clinical outcomes in MS. Dr. Graves is a collaborator in several national and international MS research efforts, and she participates in multi-center clinical trials. And just a couple of weeks ago, at the Consortium of MS Centers annual meeting, I had the opportunity to listen to Dr. Graves present on the role of biological aging in MS progression. Welcome to the podcast, Dr. Graves.
Thank you. Thank you for the introduction and for the invitation to join you.
You clearly cover the full spectrum from pediatric MS through older adulthood. What first got you interested in exploring how age impacts the way that patients experience MS?
Yes, there were two primary observations that piqued my interest in studying the role of aging on phenotypes in multiple sclerosis. The first was the opportunity to work with children with MS. Kids with MS have some similarities to adults, but they have much more inflammatory burden of disease. They have a 3 to 5-fold higher relapse rate compared to adults, but they recover better from those increased numbers of relapses than we see in adults. We also don't see the secondary or primary progressive form of the disease during childhood. On the other end of the spectrum, it's clear from epidemiologic studies as well as from general clinical practice experience that most patients who will go on to develop a progressive form of the disease tend to present with that form of the disease around the age of 45 or 50. The mean age in several studies across the world has shown that the average age of secondary progression and primary progression is 45. So looking at that spectrum and then also understanding from fields outside of MS, infectious disease and general immunology, that the immune system clearly goes through developmental changes in childhood, as well as what's called immunosenescence, or a fundamental change in how the immune system is working in the 5th and 6th decades of life, that those developmental biological issues related to aging had to play some role in multiple sclerosis.
You know, as I mentioned a moment ago, I've heard you talk about this subject before, and I found it fascinating. So I'm hoping you'll explain what biological aging is and what its role is in MS progression.
So the distinction between biological and chronological age is simply we calculate our age by our birth date, how many years since we were born. And that is relevant and it is meaningful and it has associations with certain outcomes in MS. But we might be more precise in understanding the role of aging if we use a concept of biological age. There have been studies that have been done in large healthy cohorts looking at this concept of biological age, where if you look at the function of the immune system, the brain, the heart, the lungs, the liver, the kidneys, and you try to look at what would be the biological age function of all those systems in the body, we know that if you look at thousands of 38-year-olds, there'll actually be quite a breadth of biological age when you look at all those systems. So any 38-year-old might have a biological age of 25, or some who have had certain exposures or genetic risk factors for certain human diseases might actually have a biological age that looks much older than 38, like 50 or 60. So if we hone in on biological age, maybe we'll get more detailed information about how the aging process is contributing to MS and how people experience MS, and even or just as important is how people might be expected to respond to therapies and what type of therapies might be most effective at different ages.
The last time I looked, there wasn't a lot any of us could do about chronological aging, but I'm curious, is there anything that people living with MS can do to slow down the biological aging of their brain?
Yes, that is another piece of good news. There are some things that are accessible to us that can help slow down the aging processes. And one of them that is the only really known fountain of youth is exercise. So even those folks living with MS who have harder times with exercise that depends on leg function, being able to provide ways to get cardiovascular activity with the upper body, ways to be active. There are many ways to be active and to get exercise, but that does appear to be protective and even shown in laboratory studies to reverse some of the aspects of biological aging. Diet may also be helpful. It's a certain very popular ongoing area of research with aging, is understanding if there are certain diets that are helpful. And lastly, very important, is managing any other diseases related to aging. One of the possible pathways through which aging is interacting with how people experience MS is whether there's burden of high blood pressure or cholesterol problems or diabetes, all of which become more common as people age. And all of those types of risk factors can affect blood flow and oxygen exchange in the brain. And that's very important for supporting and protecting tissues in someone battling with MS. So we also recommend patients have a primary care doctor in addition to their MS doctor, and that the MS doctor works with that primary care physician to make sure they're keeping their blood pressure in good range, managing diabetes if it does develop, and keeping the patient overall healthy, active, and those things will help combat some of those biological age processes.
Since this is one of your areas of expertise, I'd like to ask you about pediatric MS. And you briefly mentioned some of this already, but I'm wondering if you could talk a little bit about whether the characteristics of MS among children and teens, are those characteristics different than MS among adults?
A very good question. A lot of what kids go through is similar to what adult patients go through in terms of the types of attacks that are possible. As I mentioned earlier, they don't tend to get, in fact, less than 1% will have any type of progressive MS. So we don't see that expression of the disease in childhood or in teenagers. One additional difference to having higher relapse rates and more inflammation is that children with MS are unique in that their brains are still developing. So up to age 25, we're still making new connections and having brain growth. And one challenge for pediatric MS providers is how to best protect those brains through development. We like to talk with teenagers and kids and their families about how they're doing in school. This is a unique time where they're rapidly having to digest a lot of information, acquire different types of cognitive skills, which is slightly different when you're talking about a person who might be in their 30s or 40s who's already been through that development process. So we're very keen to try to keep those kids on track in terms of development, to support them, to make modifications at school that might be needed for them to achieve at the same level as their peers. So those are some special considerations. Thankfully, we don't need to support them very often with ambulatory function. Their motor recovery from relapses tends to be better than adults, and they tend to be independent in terms of gait, bowel bladder, and cerebellar function. But we do have to sometimes give extra support when it comes to mental wellness. Everyone with MS has some risk of developing a mood disorder or anxiety. But as you can imagine, adolescence is hard enough, let alone adolescents learning how to manage your MS. So we spend a lot of time working with patients and their families, trying to support their mental wellness and their independence, so that as they go through their teenage years and into their young adulthood, they can be independent self-advocates for themselves and their disease.
If we can jump forward past a few other stages of life, I'm wondering whether you've seen differences in MS among patients as they enter or go through menopause or andropause.
Yes, excellent question. It happens at that age of 45, where most of the folks who develop progressive MS might start showing early signs of developing progressive MS. Of course, not everyone, not every single MS patient will go on to get secondary progression, but when it does occur, it tends to occur around 45, 50. Very interestingly, that is during the time of ovarian aging. Many people think of menopause just in terms of the last menstrual cycle. It's a very defining moment for most women when they have their last cycle, but a lot of the interesting biology and a lot of the wild changes in hormone levels are actually happening in the 10 years before that last menstrual cycle, so what we call the perimenstrual time period. We have looked at a hormone called anti-Müllerian hormone that declines during that 10-year period of ovarian aging, and we did see an association of when that hormone declines, it indicates the function of the ovaries is starting to decline. And as that hormone declines, we did see a little bit of accelerated accumulation of disability. So the perimenopausal period may be triggering some acceleration of disability accumulation. That could be due to several factors. Estrogens are, of course, one that's always thought of when we think of male-female differences, but there's lots of other changes that are happening during the perimenopausal period biologically in women. And we are actively interested in understanding one of those factors could be targeted for a potential treatment For men, there's a less discrete time, a specific time that all men go through andropause. One way to define that is also whether men might be experiencing accelerated loss of testosterone compared to what might be expected for normal healthy aging. Usually men start losing a few percent of their level of testosterone starting after the age of 35. We do know by some epidemiologic studies that low testosterone levels may be associated with an increased risk of MS or more severe MS. It's not quite established if testosterone would be a reasonable treatment target for stopping progression. It has been looked at for men with excessive fatigue with MS because low testosterone syndrome is also associated with very significant fatigue. So testosterone is also of interest. Testosterone, we know, suppresses the immune system. We know women also have testosterone and other androgens, including progesterone, which is closely related to testosterone. Interestingly, progesterone during pregnancy might be one of the factors that leads to control during pregnancy. So a lot of very interesting work about sex steroid hormones. Not yet there with a specific hormone-based therapy that's been proven to address progressive MS, but very active areas and interesting areas of research.
As people with MS find themselves aging into their senior years, they have questions about whether or not they should continue their disease-modifying therapy. What would you say to them?
So it's a very good question and one that I would encourage them to discuss with their provider. Everybody's story with MS is different, and there are always exceptions to the rule. But generally speaking, once you've reached your late 50s, 60s, and into your 70s, on average, your chance of having a relapse is much less than when you were in your 20s and 30s or other individuals with MS in their 20s and 30s. On average, that would be the case, and it's a very reasonable time to relook at what we would call the benefit versus risk ratio for taking a disease-modifying therapy. Some of our disease-modifying therapies come with more side effects than others from being more potent modulators or suppressors of the immune system. As the immune system naturally ages in individuals with or without MS, there can be increased chance of infections as people get older. So some of our medications, that risk of infection may go up as individuals get older, or other complications. If older individuals also have diabetes or heart disease, there could be increased risk of side effects with disease-modifying therapies as well. So we would take a look at the individual, their particular flavor of MS, their risk factors and medical history, and re-examine the benefit-risk ratio. And for many, it may be a very reasonable choice to consider stopping disease-modifying therapy. In one study from Cleveland Clinic, 170 individuals stopped. This was a retrospective, what we would call an observational study, not a clinical trial. So it was by patient or physician choice. 170 individuals stopped taking their disease-modifying therapy, and only one actually had a relapse. Now, we need to study this further, and there is a current, very important, exciting trial ongoing looking at randomizing people in later life to stopping their disease-modifying therapy, and that'll give us an even more definitive answer about any adverse effects of stopping disease-modifying therapy. But it's a very reasonable dialogue to have with your provider to relook at what your chances that you're getting any benefit out of it and what the chances there could be an adverse event. And if that balance kind of switches from where you were in your 30s and 40s, it may make sense to stop.
Beyond the risk factors associated with disease-modifying therapy, are there other risk factors that people living with MS over the age of 65 should keep in mind?
Yes. So one thing to watch out for as you get older is making sure you're keeping up with all of your other health needs. We often start becoming part of the primary care team in the MS care. There are risk factors for having more progression, including development of neurovascular disease. What does that mean? Having less healthy blood vessels that are trying to bring blood and oxygen to those tissues that are battling the MS in the brain. So keeping a close eye on all the other medical problems is important. Trying to keep active into your senior years with whatever level of ability that you have to bring to that activity. Seeking support from your provider and National MS Society for access to ways to get safe, healthy forms of physical activity and healthy diet. We don't have a perfect MS diet. that's been defined yet, but certainly eating healthy types of protein, healthy fats, and decreased saturated fats would be associated with better blood vessel health and then consequently better health with living with MS.
Dr. Jennifer Graves, thank you for all that you do to improve the quality of life for people affected by MS at every stage of life. And thanks for talking with me today.
Thank you so much. Very happy to be part of this. Thank you for all that you do for people living with MS.
That's going to wrap up this episode of Real Talk MS. Real Talk MS is powered by the National MS Society. And you can share this episode of the podcast by letting people know that all they have to do is point their web browser at realtalkms.com/145. That's realtalkms.com/145. And you'll find that link in today's show notes so you can easily copy and paste it right into an email or text. I don't think I have to tell anyone listening to this podcast that the COVID-19 pandemic has intensified and in some cases multiplied the challenges of living with MS. From having difficulty affording MS medications, to adjusting to increased isolation, to coping with the added uncertainty of wondering how you or your family might be personally affected by COVID-19. More than ever before, people living with MS need access to reliable information, support, and connection. We're witnessing that even during a pandemic, MS doesn't stop, and neither does the National MS Society. So they've established the National MS Society COVID-19 Response Fund to ensure that the Society can continue meeting the urgent and expanding needs of the MS community during these unprecedented times. During the pandemic, we've seen the MS Society create virtual programming and support groups literally on the fly so that no one has to face MS alone. They've created resources and provided information so that doctors and nurses can deliver the very best care. They've continued to amplify the voices of the MS movement to influence critical public policy decisions. And they've never stopped advancing research to find cures for MS. I know that these are financially tough times for a lot of people, but I'm asking that as you're able, if you're able, please make a donation to support the National MS Society. To donate, you can text the word GIVE to 68686 and you'll get a link right to the MS Society's COVID-19 Response Fund webpage. Or if you prefer, I've created an online shortcut to get you to that same webpage, so you can visit realtalkms.com/COVID-19 Response Fund and make your donation. That's realtalkms.com/COVID-19 Response Fund, and that's all one word. You'll find that link in today's show notes. But however you choose to contribute, please contribute today. It's never been more important. I'm John Strum. Thanks for listening. Stay safe and make healthy choices.